alaikum warahmatullahi wabarakatuh. Let us discuss the further topic of this fever. So we have discussed in the previous video. So three important things are there we should uh, keep in mind in order to uh, know the etiology of fever. So number one is characterization of fever as given here. So in characterization of fever, you have 3 points. First, documentation, then duration, then pattern observation. In that, rigors, which indicate this one, and night sweats, and relative bradycardia. But the most important discriminative feature in characterization is duration of. So acute less than 1 week, subacute 1 to 3 weeks, three causes, and chronic more than 3 weeks. So this was the first point, which is very important in order to know the etiology of fever. Then the second point we discussed in the previous video was the exposure history. So in the exposure history, number one is where the patient resides and whether there is a travel history, and particularly any recent travel to the tropical areas, and if the patient whether the patient resides in the tropical areas, then any animal or vector contact, dogs, cats, livestock, stick bites, okay, and what are the occupational hobbies, medical and surgical history, then sexual history, new partners or high risk behavior. So these are the two things which we have discussed already in the previous video. Now we will discuss the third important point of to know the etiology of the fever. That third important point is ask symptoms and ask history about each symptom. Okay, either patient will say that history, or you yourself ask the patient history from head to toe of the patient. For example, if there is if you imagine CNS in your mind, then you can imagine like brain abscess. Okay, the causes can be brain abscess, encephalitis, okay, neurosurgical infection, meningitis. So among these, the most common things are sorry the common things are nothing but the brain abscess, okay, and encephalitis and meningitis. Okay, you will ask symptoms and signs, or the patient himself he will say. So what are the symptoms? Headache will be there, vomiting will be there, projectile type of vomiting will be there, or there will be altered sensorium, or there will be decreased GSS, Glasgow Coma Scale, signs of meningismus, okay, neck rigidity, all this can be there. Okay, this was the first thing. Now from head, now you will move to the eyes, and you will ask whether there is endophthalmitis, pain in the eye, okay, acute uveitis features, pain in the ear you will ask, and ears whether there is nasal obstruction, nasal discharge, and mouth you will ask for any throat pain, sore throat history. Okay, neck, where you will see whether the patient is having any lymphadenopathy. Okay, and this is the whole head and neck examination history which we should ask the patient. So here one example is given about encephalitis, which is a very common thing which you see in patients, fever with CNS features. So you can see if you do MRI with enhancement, here you can see the involvement of temporal lobe here, increased whitishness you can see. So temporal lobe, why it happened? Because of herpes simplex encephalitis. And remember, the most common cause of encephalitis is the viral cause, that is herpes simplex encephalitis in viral cause. And the next common cause is Japanese encephalitis virus. Okay. So you have asked about the head and neck symptoms. Now we'll move on to the second system. So that is uh, lung and cardiac system. So respiratory system and cardiac system. In respiratory system, you divide it into upper respiratory tract. So symptoms of sinusitis, history of post-nasal drip, whether there is headache, frontal pain, and nasal obstruction. Okay, and sore throat, pharyngitis, history of any sore throat, and if there is pneumonia, history of any breathlessness, you should ask the patient. Cough with sputum, and tuberculosis. Usually, the patient will have fever more than 2 to 3 weeks, and patient will have cough, maybe associated with sputum or not. Lung abscess, you can ask the patient. So that patient will have what do you call foul smelling sputum. Foul smelling sputum patient may have, and uh, copious amount of sputum you may have. Empyema patient will have pleuritic type of chest pain and breathlessness on lying on one side. So these things you will ask, keeping these systems in mind. Okay, then you will ask the cardiac features, whether there is history of chest pain or palpitation. Okay, to rule out any endocarditis, pericarditis. Okay, that's about the GI system. Sorry, respiratory and cardiac system. Similarly, you should ask history about the GI system. So you should remember these common infections. Then only you can ask this history regarding these. See here, should remember this common system, then only you can ask history about regarding them. So in the head and neck, you should remember these causes, and in respiratory and cardiac, you should remember these causes. And now coming to the gastrointestinal, meaning abdomen. So in abdomen, you should remember the anatomical structures. Okay, in chest, you will have lungs and heart. In head and neck, you remember the structures, and in GIT, meaning abdomen, you will have liver, gallbladder, and the biliary tree, pancreas, colon, intestine, kidney, and the urological system, uterus, fallopian tube, ovaries, appendix, diverticula sometimes. So if you remember these anatomical structures, then you will have your the diseases in your mind. So liver abscess can be there, pertaining to the liver. Hepatitis can be there. So pertaining to those symptoms, you should ask the symptoms. Patient may have fever with jaundice, fever with right upper quadrant pain. In this biliary infection, patient usually has fever with right upper quadrant pain with vomiting. Okay, pyelonephritis, again, patient will have fever with flank pain and burning mutation sometimes and vomiting. Colitis, patient will have history of fever, abdominal pain, colicky type, and dysentery, meaning mucus of blood with stools. Peritonitis, inflammation of the peritoneum, usually due to perforation. So you can have rigidity guarding of the abdominal vessels or rebound tenderness. Tubular urine abscess, you can see in females. Okay, female patients can also have pelvic inflammatory disease. Okay, appendicular abscess. So if you palpate, you have some mass. Diverticulitis. Okay, same patient will present with fever with diarrhea. Okay, in patient with diverticulitis. So like this, you should ask. You should remember the structures, and you imagine the system in your mind and ask localizing systems and symptoms and signs. So this is a CT which shows liver, enlarged liver because of abscess inside, and here it is a CT again showing a diverticular mass. Okay, so that's about the system. So skin is also an organ, no? Skin, joints, bone. So pertaining to those, you should ask. Okay, like this. See, you can see here a patient with cellulitis, but X-ray is done in this patient. You can notice here there is a collection of some collection inside the lower part of the tibia in this patient. Okay, so imagine the structures like this. If this is the epidermis, and this is the dermis, and this is the subcutaneous fat, this is the deep facial planes, meaning this is the superficial fascia, this is the deep fascia, and this is the muscle, and this is the bone. So infection in epidermis and dermis is nothing but impetigo, erysipelas. Okay, and if extends into a superficial fascia, then it is cellulitis. Extends to deep fascia, then it is necrotizing fasciitis. Involves muscles, that is pyomyositis. If it involves bone, that is osteomyelitis. So like that, you can divide the you can ask the patient history, any pain in the periphery, like that, or any pain in the joints, septic arthritis, you can ask. So that's how you ask the patient uh, symptoms pertaining to each system, and you will ask the sign. So that's these are the three important things in knowing the etiology of fear. First one is documentation. In documentation, you have three things. Sorry, first one is characterization. Characterization. Characterization, you will document the fear first. Document, and duration is the most important thing in deciding the etiology. Then some features like rigors, rigors, night sweats. Okay, and uh, next thing is rigors, night sweats, fidget sign, important sign, relative bradycardia. So this is the first important thing. Okay, and the second important thing is exposure history. Four things in that. Third important thing is ask history about localizing features. So these three things will help us to reach the diagnosis. Okay, now sometimes there will be only fever, sometimes many of the times there will be only fever and no localizing signs and symptoms. So the management of that is different, we'll discuss in the management part. Now physical examination, how you will perform. Again, same thing here also, head to toe you should perform the physical examination. So head to toe you should perform this physical examination. How you will perform head to toe? General survey first, then skin and soft tissue, then hint. Hint is nothing but H for head, E for eyes, E for ears, N for nose, T for throat. One more thing is neck. Okay. Throat involves neck. Okay. Then cardiovascular. Sorry. Then cardiovascular and pulmonary. You can take chest, meaning nothing but chest. And then abdomen and musculoskeletal. That's how you examine the patient from head to toe. Now, coming to the general survey first. The physical examination of febrile patient is a hunt for soft signs, subtle clues that point to the source. So, in general survey, see the mental status of the patient. If the patient can have delirium, especially in elderly and children individuals, and patient can have new confusion state. That points to, if the patient has new confusion, then that points towards sepsis. Okay, or CNS infection. Remember this point. So, new acute confusional state can points towards sepsis or CNS infection. Sepsis or CNS infection. Okay, and delirium. Older individuals can usually present with delirium, and they will have a blunted response to fever. Delirium and acute confusional state. Okay, vital signs: hypotension if it is present, that represents septic shock. Tachypnea if it is present, that represents respiratory compensation for metabolic acidosis. So these are early systemic clues of severe infection. Okay, then skin and soft tissue. Coming to skin and soft tissue. So in skin and soft tissue, you can have petechiae and purpura. This is different from rash. This is nothing but bleeding inside the skin. Purpura is nothing but bleeding inside the skin, and this is hemorrhagic necrosis of the skin due to vasculitis. Okay, so petechiae and purpura, how you differentiate it from rash? So these will not blanch when you press the skin, but other rash will blanch when you press the skin. That's how you differentiate petechiae and purpura from other rash. So these are non-blanching spots. So these point toward meningococemia, which is an emergency. Okay, sepsis state. Vasculitis, endocarditis. Okay, that is a very important emergency, petechiae and purpura. Eschar indicates necrotic black crust with erythematous. You will have a blackish colored crust surrounded by erythema. Images we will see. Okay, so that indicates scrub typhus or rickettsial pox due to tick bite. That these are the two important things in skin. Okay, then these three, 1, 2, 3 Janeway lesions, ossular nodes, and splinter hemorrhages are because of endocarditis. Janeway lesions are nothing but non-tender hemorrhagic macules in the palms and soles that indicate endocarditis. Ossular nodes are tender nodules on fingers or toes. Again, that is endocarditis. Splinter hemorrhages are linear streaks under nails. They indicate either endocarditis or trauma. Rose spots are salmon colored macules on trunk, which is seen in typhoid fever, and this is very rare actually. Okay, this is very rare. Track marks like IV drug abuse. Track marks indicate IV drug abuse. Risk of right-sided endocarditis in these patients. Risk of hepatitis in these patients. Risk of spinal epidural abscess in these patients. So if you are dealing with any IV drug abuse patient, then you should think of these diagnoses. You should have hepatitis, endocarditis, right-sided, and epidural abscess in your mind. So skin is a diagnostic window. Many systemic infections manifest in the skin. So don't neglect the examination of skin. Next, coming to the head and neck. So in head and neck, you see the eyes. So conjunctival suffusion is what? Redness of the eye, redness of the conjunctiva, along with fever. So it can indicate either acute uveitis also you can think of, but systemic infection like leptospirosis, it is an important sign of actually it is a hemorrhage below the conjunctiva. So that is known as conjunctival suffusion. So if you do fundoscopy, road spots you can see that is towards that points towards endocarditis, and you find choroidal tubercles again in fundoscopy that points towards biliary tuberculosis. Okay, road spots in endocarditis, choroidal tuberculosis in biliary tuberculosis. Neck, if there is neck rigidity, nuchal rigidity, that points towards meningitis. If there is lymphadenopathy, that may point towards tuberculosis, lymphoma, and infectious mononucleosis. Okay, tuberculosis, lymphoma, and infectious mononucleosis. In mouth, if you see whitish patches, that point towards candidiasis or thrush, and that is a sign of immunosuppression. So that may indicate HIV or diabetes in the patient. So any patient coming with candidiasis or thrush, whitish patches in the mouth, Always rule out diabetes and HIV, or the patient may be on some immunosuppressant medications, or he may be taking some inhalers, mouth, which is very much common in inhalers for asthma. So that steroid is deposited in the mouth, and because of that, he may have developed this candidiasis. So thrush, you can see dental caries. What does it indicate? It can be a source of lung abscess or endocarditis. Another thing is tonsillitis. You can see tonsils will be there, and tonsillar abscess you can have. Okay, tonsillar abscess, and pharyngitis you can have pharyngitis. So these you see in uh, oropharynx. Okay, so this is about head and neck. What you see. Then in the cardiovascular system, you examine for these. Sorry, these things. If you see a new murmurs, like new regurgitant murmur, that is a hallmark of infective endocarditis. It can be aortic regurgitation or mitral regurgitation. Prosthetic sounds, meaning in patient who have artificial valves in their heart. So you can hear muffled clicks in valvular replacement. That indicate valve thrombosis or vegetation. Remember this one, valve thrombosis or vegetation. Uh, Again here, pulmonary is not given. So in pulmonary, you can have crepitations. You can hear crepitations. You can have rhonchi, uh, rhonchi and crepitations you can hear, or you can hear bronchial breath sounds also. Bronchial breath sounds. So these indicate some lower respiratory pathology. Now, strong indicators of endocarditis are prosthetic valve complications. So murmur, presence of a murmur in a patient with fever, new regurgitant murmur, that points it is a strong indicator of endocarditis. Then coming to the abdomen, chest you have examined, now abdomen you should examine. So abdomen, there is liver and spleen. So hepatomegaly you can see in patients. So if there is hepatosplenomegaly, both liver and spleen are enlarged, that you will know by percussion. Okay, that suggests malaria, very important diagnosis. Typhoid, particularly in tropical countries. Okay, malaria, typhoid, brucellosis, leishmaniasis. So all these are diagnoses of tropical countries. Brucellosis, leishmaniasis, malaria, typhoid should be your first diagnosis. Then lymphoma can also present like this, or either there can be isolated hepatomegaly or splenomegaly also. Isolated splenomegaly you can see in patients with infective endocarditis, and isolated hepatomegaly you can see in patient with viral hepatitis or liver abscess. Okay, then coming to the joints. Okay, joints and okay, if hot, swollen and restricted joint is there, then you can suspect septic arthritis. Spine, what you should see, percussion tenderness if it is there in the spine, then that may point towards vertebral osteomyelitis or discitis. Fever with back pain. Okay, that's how you will see this uh, subtle clues from head to toe. So this is an important picture, very important. So we should examine like this. Actually, this is, and this applies to every uh, uh, system disease. So whenever you examine, you should go like this: from the hands, arms, then head and neck, then respiratory cardiac, then abdomen, then genitourinary or uterus, then joints and skin, and then lower limbs. So this should be our, so like this round examination you should do. So this is the method of Davidson. Okay, the Davidson usually gives this type of, it is very easy to examine. So first of all, you should uh, observe the patient generally. The patient may have as a general observation. Okay, temperature, sweating he can have, weight loss he can have, respiratory distress you can notice, altered consciousness you can notice, pallor you can notice, jaundice you can notice. The next comes the skin. Skin is very important, no, to examine. So you can have generalized erythema, rash, IV injection track marks, surgical scars, some venous catheters or tattoos. Okay, these point towards some specific pathologies. Then in the second thing, you will see the hands and nails. You can have finger clubbing. Okay, splinter hemorrhages, Janeway lesions, signs of chronic liver disease, vasculitis lesions. Okay, this is a picture of splinter hemorrhages. Here you can see. Okay, then after examining the hand and nails, what you will do, you will palpate the pulse. You will palpate the pulse here, and then you will measure the BP, and then you will get to the head and neck. So in head and neck, what you will see, coming from upside down, neurological, you can have nuchal rigidity, neck stiffness, photophobia, delirium, some focal neurological signs, like patient may not be able to talk, or patient may not be able to move his one limb or two limbs. So these are all focal neurological deficits. So that indicates some CNS pathology. Then from head, you come to eyes. You can have conjunctival petechiae. That indicates again leptospirosis, like that. Painful red eye indicates uveitis. Loss of red reflex in endophthalmitis. Rod spots in infected endocarditis. Hemorrhages and exudates of cytomegalovirus retinitis. Choroidal lesions of tuberculosis. So road spots in infected endocarditis. This is tuberculosis. This is CMV retinitis, and this is endophthalmitis. This is uveitis. Okay, these are road spots which you see. Okay, then coming to eyes you have seen. Then come to ears, which is not given here. So ask any ear discharge, ear pain, okay, nasal obstruction, and you palpate the sinuses, whether there is any frontal tenderness, maxillary tenderness. That will give you a clue to sinusitis. Okay, then you will come to the neck part. Sorry, the first, then you come to mouth, the oral cavity. So in the oral cavity, what you can see in examination: dental caries. Dental caries you can have, tonsillar enlargement or exudate you can have, candidiasis you can have. So this is a picture which shows, see, there is congested tonsils and enlarged tonsils. So this is streptococcal tonsillitis. And then you come to the neck. So you can see the enlargement of the submandibular parotid or submental lymph glands, or you can have parotidomegaly, a large parotid gland, or abnormal tympanic membrane in the ears, perforation, otitis media. Okay, so you have examined the head and neck. Now you come to the uh, heart, the chest. Chest you will have lungs and heart. So tachycardia and hypotension you can have, murmurs and or prosthetic heart sounds you can have, pericardial rub you can have, signs of consolidation, pleural or pericardial effusion. So this is a chest X-ray showing lower lobe consolidation here. Yes, lower lobe consolidation in pneumonia. So that's how these you can see in chest. These are the chest signs you can see. Then you come to abdomen. In abdomen, what you can find out, you can find hepatosplenomegaly or either isolated hepatomegaly or splenomegaly. Ascites you can have, renal tenderness, localized tenderness or guarding with decreased bowel sounds. Example in left iliac fossa with diverticulitis. Mass lesions you can have, surgical drains. Then you come to the musculoskeletal system. So in that you can have joint swelling, erythema and tenderness, localized tenderness of the spine which suggests epidural abscess or discitis, draining sinus of chronic osteomyelitis. Then you come to genitalia and rectum. So you can have ulceration or discharge, very important, testicular swelling or nodules, inguinal lymphadenopathy, also known as bubo, prostatic tenderness, rectal fluctuance, indicating some rectal abscess can be there. Okay. So you can see here testicular swelling in adult bumps, and in female patients you can have by discharge PV, and you can have if PV examination is done, cervical motion tenderness you can have. These things can be there. So this is how examination should be done from head to toe in a patient coming with fever. Okay, so these are some pictures, the skin, what you can findings. So you can see here, this is a eschar. This is eschar. Okay, this is a blackish crust surrounded by erythema, mainly found in the hidden areas like axilla, groin, inflammatory area. Okay, so this is pathognomonic of tick bite, so rickettsial fever. Then you can have you can see here these things. This is a peripheral maculopapular eruption which is appearing on the palms. So this is a feature of, and these are non-blanching. Okay, sorry, these are blanching. That means this is a feature of Ronchi-Montet spotted fever. And you can see Nikolsky's sign here. What is that Nikolsky sign? This is a neonate. If you just give a lateral pressure to the skin is easily peeled off in this neonate. So that is a feature of staphylococcal scalded skin syndrome. Okay, and this is a vesicular rash. So vesicular rash, this is the vesicle and this is surrounded by erythema. So this is known as dew drops on rose petal appearance. Okay, so this is seen in varicella, chickenpox or zoster also. In zoster it will be restricted to one dermatome or multiple dermatome if the patient is immunocompromised, and in varicella it will have centripetal distribution. So this is an arterial rash which is seen in an allergic patient, or in an anaphylactic in a patient with allergy. Okay, arterial rash. See this. So this is a nodular lesions on the face of a patient with disseminated cryptococcus infection. And cryptococcal infection usually doesn't occur. Remember, it occurs in HIV patients. So having cryptococcus infection means that patient should be screened for HIV. And this is purpura. This is bleeding in the skin. This is purpura fulminans in a patient with acute meningococcemia. Acute meningococcemia. Okay. And this you can see, this is a maculopapular rash. Okay, involving the trunk, centrally distributed. So this is a case of measles. And here you can see here. So this is a petechial rash. Petechial rash. So either this can be vasculitis or it can be meningococcemia. Meningococcemia. Okay. Petechial rash. Again, you can see here there is erythema, and that erythema is blanching here. You can see the hands blanching erythema. So this is a picture of streptococcal shock syndrome. Again, here you can see vasculitic petechial rash. So this is a feature of meningococcal sepsis. So this is dermatomal distribution of vesicular rash seen in shingles, and this is a patient with erythema nodosum, nodular eruptions on the shin, lower limb. So which is seen in granulomatous diseases like tuberculosis and sarcoidosis. So skin is a window to diseases. So points to remember in fever in old age. Temperature measurement. Fever may be missed because oral temperatures are unreliable. Rectal measurement may be needed, but core temperature is increasingly measured using eardrum resistance. Delirium is common with fever, especially in those with underlying cerebrovascular disease or dementia. Okay. Prominent causes of pyrexia of unknown origin include tuberculosis, intra-abdominal abscesses, complicated urinary tract infection, and infective endocarditis. Non-infective causes include non-infective causes polymyalgia rheumatica, temporal arteritis is a very important cause in elderly, and tumors. Okay, and infective causes of FUO, which is a separate topic we will deal. It is tuberculosis, intra-abdominal abscesses, complicated UTI. Okay, pitfalls in elderly. Conditions such as stroke, thromboembolic disease can cause fever, but every effort must be made to exclude concomitant infection in these patients. So if they have stroke, you should also exclude infection. Common infectious diseases in the very fail, they are pneumonia, urinary tract infection, soft tissue infection, and gastroenteritis. And remember, because the elderly patients have blunted fever response, most of the time they present as delirium. Okay, altered orientation of the patient. They will have an acute confusional state. Sometimes patient may present with only symptoms, fever, and they will not have any fever, or less, very low grade fever. Okay, they will have. So you should suspect at that time only the patient may be having some infection. Now coming to what are the initial diagnostic tests. Now you have documented characterized the fever. You have taken a proper history proper exposure history, and you have asked history about localizing signs and symptoms, and examined also. But you have documented the fever, but there is no immediate localizing signs for the patient. Now for the patient with no immediate localizing signs, immediate by meaning of immediate is less than 4 days. Remember this one. This is according to Merck's Manual of Medicine. For the patient with fever with no immediate localizing signs and the duration of fever is less than 4 days, and patient is not in sepsis, patient does not have any red flags, patient is stable. So in that patients, for the first 4 days you should not do anything. For the first 4 days you should not do anything. After 4 days, you can plan. Again you should take history one more time, and one more time examine the patient. Again, if you don't find any symptoms or signs, then you should have these initial tests. So for the patient with fever and no immediate localizing signs, a structured screening panel is required to identify occult infection or inflammation. So what are those investigations? Those include hematology, CBC with differential. Okay, CRP and ESR, procalcitonin, inflammatory markers. Microbiology, blood culture and urine culture. Imaging, chest x-ray and abdominal ultrasound. So these are the things we should do according to the book. In CBC, if you have neutrophilia, that suggests bacterial infection. Lymphocytosis suggests viral infection, tuberculosis or pertussis. I will just zoom it in. Neutrophils suggest bacterial infection, lymphocytes suggest viral infection, tuberculosis or pertussis. Eosinophils suggest parasitic infection or drug reaction. Pancytopenia means bone marrow infiltration, that means leukemia or leishmaniasis, Kalas are also known as, or severe sepsis. You can have pancytopenia and severe sepsis. Okay, leukemia and severe sepsis and Kalas. Thrombocytopenia you will have in malaria, dengue, particularly in malaria, dengue you suspect, and sepsis also you can have this thrombocytopenia. So pancytopenia and thrombocytopenia in severe sepsis you can have pancytopenia and thrombocytopenia. So that is a red flag, I think. Okay. Now coming to the inflammatory markers. So CRP and ESR, they have a high sensitivity but low specificity. That means they say that there is inflammation, but they will not tell you whether the inflammation is due to infection or some other non-infective cause. Useful for tracking response to therapy. Useful for tracking response to therapy. When you give therapy and that therapy is targeted, and infection, if it is going, then these will come down. Normal, this is important point. Normal CRP has a high negative predictive value for bacterial infection. Normal CRP has a high negative predictive value for bacterial infection. Okay. Then what is this procalcitonin? This is more specific than CRP for bacterial infections. Helps differentiate bacterial versus viral infections. This is useful in guiding antibiotic therapy, initiation and discontinuation. This is elevated in severe bacterial sepsis and systemic infections, but it is usually low in viral infections and inflammatory conditions. Then you should send for blood cultures, 2 sets of blood cultures, one for aerobic, another for anaerobic, from separate venipuncture sites before giving antibiotics. Number 2, essential for diagnosing bacteremia and endocarditis. Urine culture to rule out occult, meaning minimal urinary infection or pyelonephritis, kidney infection. Chest X-ray is mandatory to rule out pneumonia or tuberculosis even in the absence of cough. Abdominal ultrasound, high yield, low screening tool for liver abscesses, biliary pathology, splenic abscesses, organomegaly. Okay, these you can do. So these are the initial tests. What are the tests? CBC with differentials, CRP, ESR, and sometimes procalcitonin, blood culture, urine culture, chest X-ray, and abdominal ultrasound. Okay. One more thing you can add here is malaria. For malaria in tropical countries, peripheral smear you can add for any parasitic cause. Peripheral smear. Okay. Now this is the summary flow chart, and very important, very important flow chart. One should remember, okay, to approach a patient with fever. Master flow chart of fever. So first you see a patient with fever. Ask yourself initial triage whether the patient is unstable or whether the patient has red flags. If yes, then emergency evaluation and stabilization should be done. ABCs, IV access should be taken. Laboratory investigation should be sent. Culture should be sent, and empirical broad spectrum antibiotic therapy should be given. Consider chest X-ray and ultrasound in these patients who are unstable and who have red flags. Now the patient patient is stable and they don't have red flags. Then you will search for any localizing symptom or sign in these patients. If you have a localizing sign and symptom, targeted history and examination should be done. Direct testing based upon the site. For example, if chest is involved, sputum you can give for microscopy and culture. If there is burning micturition, you can give urine for microscopy and culture, wound culture. Okay. If there are no localizing symptoms or signs in the patient, then you assess the risk and duration of fever in this patient. If the duration of fever is less than 4 days and there are no localizing symptoms and signs, and the patient is at low risk, meaning no red flags, then you should observe for 4 days. After 4 days, you can plan for investigations. Now, if the fever is subacute, meaning if it is more than 4 days up to 3 weeks duration, okay, or if the patient is at high risk, then you can send the initial battery of investigation which we have discussed just now. CBC and malarial parasite, peripheral smear for malarial parasite, ESR, CRP, LFTs, urine analysis, blood cultures, okay, urine culture, chest X-ray. If the diagnosis is found after this, then treat the specific cause. If the diagnosis is not found and 3 weeks have gone in that, then that will go into something called as fever of unknown origin. That itself has this different protocol. There you will take again, review all the data, repeat history and physical examination, consider HIV, Epstein-Barr virus, CMV serology, consider autoantibodies, meaning connective tissue disorder, CT chest, abdomen, pelvis, 2D echo for subacute bacterial endocarditis. FDG PET is the last thing to do, no signs, so which we do. Okay, PET CT and biopsy for clues. Okay, this is a master flow chart to evaluate a patient with fever. So this is the summary of the whole topic: fever core concepts and management. So patient presents definition is temperature more than 30 degrees Celsius due to increased hypothalamic set point. Pathophysiology is simplified. Germs or pathogens will activate the immune system that will secrete cytokines 1,6 TNF, IFN, and brain there will be increased PGU2 that will increase the hypothalamic thermostat raised. Shivering, vasoconstriction will be there. And if the patient has very high grade fever, meaning more than 41.5 degrees Celsius, meaning it is not fever, it is hyperpyrexia, there is risk of CNS. So aggressive cooling is required. Now, if the fever is more than 38.3 degrees Celsius and it is more than 3 weeks have gone, diagnosis is unknown, then it is known as fever of unknown origin. So management organ for sepsis. Suspect infection plus SARS, 2 out of 4 criteria. Give oxygen, take blood cultures to before antibiotics, give empiric broad spectrum antibiotics within 1 hour, measure the lactate. If it is more than 4, that indicates septic shock. Give fluid bolus 30 ml per kg crystolite. If it is not responsive, give vasopressors like NORAD, Noradrenaline. Monitor the urine output. Identify and control the source. Now, what are the red flags and pitfalls in summary? So the red flags: petechial rash with fever, meningococcemia until proven otherwise, travel plus fever, malaria until proven otherwise, post-operative fever with hypotension, anastomotic leak or abscess, fever with new murmur, endocarditis until proven otherwise, fever with bone pain, osteomyelitis or metastasis until proven otherwise, fever with headache with 50 years of age, temporal arteritis, risk of blindness. Steroid therapy may mask fever and infection severity. Negative cultures do not rule out infection. Okay, and that should be taken prior antibiotics. Negative cultures do not rule out infection. Clinical one-liners: treat hypothermia with cooling, not by antibiotics. In FUO, common diseases present uncommonly. Okay. When you hear hoofbeats, think horses, but don't forget zebras. If the patient is from Africa, travel history. Okay. Antibiotics treat bacteria, not fever. Steroids before ruling out tuberculosis can be disastrous. The best diagnostic tool in FUO is repeated examination. Now, how you will manage symptomatically in this patient? You should give paracetamol. NSAIDs should not be given because they will mask the signs in the patient. Usually, they should not be given. And if you want to give NSAIDs, ibuprofen you can give along with paracetamol if the fever is very much uncontrolled. Ibuprofen, short acting NSAID. Otherwise, paracetamol and fluids should be the only things uh, used to treat the patient symptomatically. Okay. Thank you. We have ended the topic of fever here, and we will discuss a new topic in the next video. Thank you.